Moving on to the next topic, we'd like to call upon the chairperson, Dr. Balaji Jagan Mohan, who is the consultant endocrinologist at Apollo Sugar Clinics, Bengaluru. We welcome you on stage, doctor.
So good evening, everyone. It's a pleasure to be here at the ILET conference. I'd like to thank my good friend Dr. LSM for having had invited me. And I'm happy to chair this session for Dr. Muruganathan, who's a very senior physician diabetologist, very famous across the country. And he's done a lot of work in the space of internal medicine and cardiodiabetic disease. So if you can come over to the stage, sir. So Dr. Muruganathan is a consultant physician and a diabetologist at the AG Hospital in Tamil Nadu. He's a past state president of IMA, past IMA Building Committee chairman, and past dean of IMA CGP. He is a recipient of the BC Roy Awardee, and he is an adjunct professor at the Tamil Nadu Dr. MGR Medical University. So he is going to speak on anemia and chronic conditions and what is the role of Ferric Maltol. So over to you, sir.
Good evening. Good evening. Yes, I know. I'm happy that, some of you are awake. Thank you, Chairperson. And at the outset, I must thank Srinivasa Murthy for having chosen me for this subject. Of course, this is a sponsored topic. Red alert, iron deficiency anemia in chronic conditions and role of Ferric Maltol. It's actually a silent epidemic. I'm very happy the previous speaker spoke on the importance of nutrition. So I will also touch upon some of the nutritional aspect of my talk. Silent epidemic, iron deficiency anemia, far more than a laboratory abnormality. It is the silent thief of energy, productivity, and quality of life. It is a global health crisis with profound clinical, social, and economical consequences. Our nation is built by stone and steel. Our body is built by blood and bone. When iron runs low, our life goes slow. So always remember this phrase. I'm very fond of telling like this. Despite the most prevalent nutritional disorder worldwide, it remains significantly underdiagnosed, undertreated, particularly in patients already managing chronic disease. See, when people have more chronic disease, they are more worried about their disease, the main disease. They forget about the iron deficiency or anemia. Iron plays a very crucial role in the oxygen transport, cellular metabolism, enzymatic and mitochondrial function. Deficiency leads not only to fatigue, cognitive impairment, reduced immunity, and poor quality of life. One big problem is when somebody is not anemic, we don't check iron. And that fellow gets fatigue, and then they get into a lot of problems. So whenever you treat anemia, think about iron also. You will have to do the tests. Iron deficiency accounts for 70% of all cases of anemia. It's not an isolated diagnosis. It always accompanies with other diseases. Its pathophysiology is multifactorial and differs by condition, requiring nuanced treatment approach. For example, in inflammatory bowel disease, where it's a chronic disease, 70% of the IBD patients due to a triad of malabsorption, chronic gastrointestinal blood loss, and systemic inflammation that dysregulates iron metabolism. In chronic kidney disease, again, a highly prevalent comorbidity driven by erythropoietin production, impaired iron utilization, and uremic inhibition of erythropoiesis. In chronic heart failure, now I think all the cardiologists, even in every cardiology conference, there's a topic on iron. How iron is helpful in heart failure. Iron deficiency occurs in heart failure up to 50%. It independently predicts hospitalization and mortality, even in the absence of anemia. That is the point you must know. Even in a heart failure, there may not be anemia, but still a crucial need of iron in the proactive iron assessment is very important. These are the conditions where iron deficiency is prevalent. 50% of the heart failure, 50% of CKD patients, 76% of surgery patients, more than 50% of the pregnant women, 69% of women with heavy menstrual bleeding, 30-60% of cancer patients. I am glad our American College of Physicians Governor Swati did a program on women's health on these aspects. 36 to 76% of IBD patients. What are the causes of anemia? I mean, just to refresh, it can be physiological, it can be environmental, or it can be pathological. Physiological, when there is increased demand during infancy, adolescence, menstrual blood loss, pregnancy, and frequent blood donation. Some people enthusiastically give frequently, every birthday, some leader's birthday, they give blood without, checking the iron. Environmental, insufficient intake, poverty, malnutrition, diet. And then pathologically, it can be decreased absorption due to gastrectomy, bariatric surgery, chronic inflammatory disease, acute or chronic blood loss, hemorrhoids, IBD, menorrhagia, malaria, etc. And of course, drug-related also, you must remember, when you give salicylates, NSAID, and proton pump inhibitor, and day in, day out, we are giving proton pump inhibitor. There is a relationship between iron and the proton pump inhibitor. And then what are the symptoms? Sometime back when lady came, she had she had a hair fall. When we analyzed, iron was deficient. So hair fall also is a cause for the hair fall. Iron deficiency is also for a hair fall. Shortness of breath, fatigue, brittle nails, if you see. And then some people have increased sensitivity in cold. See, for example, when you go to a hall, some people will feel more chill. My friend Swati will say thyroid, but you can also look for iron. Now, cardiovascular system, tachycardia, risk of angina, heart failure, lungs, of course, we already said, cognitive dysfunction, stroke, depression. And then this is what is commonly seen: chronic fatigue, weakness, reduced physical endurance. And immune system, there is reduced immunity. Reproductive system also, there is a problem. GI, of course, impaired digestion. And renal system, reduced renal functioning. So that means it involves all these systems. So how do you diagnose? Very simple. According to WHO, anemia is defined as the hemoglobin levels less than 12 grams in non-pregnant women and children, 13 grams, less than 13 in men, and less than 11 grams in pregnant women. I say this definition because Ashok Kumar Das will agree. When somebody comes, for a man, if it is 11 gram, we take it, chalo, next time. Don't do that. When there is a less hemoglobin, just look into the problems. Of course, these are the investigations you have to do: RBC, hemoglobin, MCG. See, mean corpuscular volume is important. Then only you will know it is microcytic or macrocytic. And then again, hemoglobin, I've already told you the various levels. Now, coming to iron profile, you must measure serum iron. For male, it is 80 to 180. For female, 60 to 160. Serum ferritin, very important. The iron stored in the body, 12 to 300, and female 12 to 150. When I say serum ferritin, you must also think about chronic inflammatory disease where the ferritin may be more. So don't go with that. But anyway, in a chronic inflammatory condition, along with serum ferritin, you have to do ESR and CPR, CRP. Then only, you can correlate. And total iron binding capacity, and then transferrin saturation. These are the tests which we do for iron. Now, management of iron deficiency anemia. One is you have to find out what is the cause, the specific cause, and then you have to treat. Dietary intervention, oral iron, parenteral iron, of course, it all depends on the individual patient. Now, dietary modification, the previous speakers spoke about nutrition. The heme iron sources are fish, shellfish, red meat, chicken, legumes and beans, dry fruits and seeds, jaggery. Now, it's a very fashion in every national highways, you can get jaggery coffee. People go and take jaggery. Fruits, especially strawberry, watermelon, and then eggs, of course, green leafy vegetables, tofu. And then eat vitamin C, it will help in absorption. Very important point, tea contains tannin. and phytates that can block absorption of iron. So please avoid drinking tea 1 hour or before 1 hour before and after the meal, so that iron absorption may not be obstructed. Then oral iron is the main therapy, and this is the evaluation of how oral iron has come from organic, inorganic, ferric, ferrous, chelated iron, liposomal iron, elemental iron, etc. Now, these are the oral preparations you could have come across every day in the market. Ferrous sulfate, ferrous fumarate, ferrous gluconate, ferric ammonium citrate, ferrous ascorbate, ferrous bisglycinate, then liposomal iron. What is important is, in every tablet, you must look for what is the elemental iron, what is the bioavailability. For example, ferrous sulfate, the elemental iron is 65, whereas bioavailability only 7 to 10%. So though the bioavailability is, elemental iron is there, you don't get the bioavailability. If you don't get it, it will be circulating in the intestine, free radicals that will damage intestinal mucosa. That is very important. So whenever you consider an iron tablet, you must also look for elemental iron as well as bioavailability and the route of absorption and metabolism of that target. Elemental iron, amount of iron in a supplement that is available for absorption. What is bioavailability? Fraction of the elemental iron that reaches the systemic circulation. So these two are important. Whenever you see a oral preparation, what is this? So recommended daily dose for the treatment of iron deficiency in the range of 100 to 200. So if you take ferrous sulfate, which is 325 milligram, where you get elemental iron of 65, you will have to take 3 tablets. And in that, only 25 milligram will be absorbed and utilized. The rest all will be going as a free radical and damages the intestinal mucosa. It produces a lot of problems. The downsides of conventional, I told you, low availability, poor iron absorption. So if it's the ideal drug, you should have good availability, good absorption. And less stable iron complex if you take ferrous sulfate, and dislocation of ferrous salt complex at acidic pH level. Then GI intolerance, large elemental iron doses, the fractional iron absorption decreases, large amount of unabsorbed iron, free radicals generated can cause gut inflammation, mucosal toxicity. Then the gastrointestinal worse with the ferrous sulfate, metallic taste, nausea, constipation or diarrhea, vomiting and black stools. Up to 60% of the people taking traditional oral iron report GI disturbance. Because of that, the adherence is not there. They don't take it. So you have to have a patient-friendly patient who can tolerate the iron. So unabsorbed iron leads to free radical generation, impact on intestine, I told you, promotes inflammation, mucosal injury, impaired barrier function. One of the important thing, of course, I'll be telling you next slide. Now we call it the microbiota is the game-changing molecule. So wherever there is a microbiota dysbiosis, you have problem. See, recently they found out even in hypertension, if you take salt, the salt can produce dysbiosis. Even sleep disturbance can produce dysbiosis. My friend from Vellore has come, Petri. We are going to strongly associate all the microbiome specialists. We want to do a lot of work on that. And then this iron, which is free radical, it also causes dysbiosis. So microbiota disturbance, that also can produce a lot of problem. And of course, you must have a iron preparation without all these side effects. Now, coming to the Ferric Maltol. It's an innovative approach, bridging efficacy and tolerance in anemia management. The Ferric maltose is a ferric ion with maltose. So 3 molecules are there. It's a novel, stable, non-salt based iron. What is the advantage of the maltol when it is attached to ferric? It has got antioxidant effect, antimicrobial effect, low toxicity, high bioavailability, high stability. It is lipophilic properties and strong metal binding affinity. What are the advantages of this ferric maltol? Stomach, duodenum, intestine, one by one. In stomach, no dissociation at acid pH, unless the other iron tablets. Less food-drug reactions. Low mucosal toxicity. Duodenum, lipophilic properties, unique absorption mechanism, causes high bioavailability, effective absorption at lesser elemental iron dose. What are the stable complex? Low mucosal toxicity, antioxidant effect, and no gut dysbiosis. So benefits of better absorption, reduced mucosal toxicity, less interaction with medicine, no effect on gut microbes. Now coming to comparison of the ferric maltol versus conventional oral iron preparation, I told you ferrous sulfate dissociate at the acidic pH, whereas in ferric maltol no such things. And in ferric salt, you have unstable form of iron. Unabsorbed iron in the gut leads to poor GI tolerance, and ferrous salt complex dissociate in the stomach, less elemental iron, whereas ferric maltol complex dissociates in the duodenum. And so these are the difference. Whereas in ferric maltol, 30 milligram of elemental iron is there, and rate of adverse effect is only 1 to 4%. And then better compliance with ferric maltol. And if you see the ferric maltol compliance is 97%, and patient adherence is good. It is 2 times greater absorption with ferric maltol than ferrous sulfate. Ferric maltol effective in patients intolerant to ferrous preparation, and then increases the hemoglobin in spite of patients taking PPI. Even in PPI patients, there is a good HB increase after 3 weeks, and up to 52 weeks it can be compared to parenteral iron also. And then intestinal microbiomes, I already told you, there is no influence on gut microbiome. And then if you see the ideal characteristics of any ferrous salt should be negligible, should be absent the labile iron release, oxidative stress. All these unwanted effects are not there, and plus points are there in ferric maltol. That is why it is closer to ideal oral iron. And IBD, we use this, and then also we use in chronic diseases like kidney disease, chronic heart failure. Everywhere iron is useful because of the safety profile, and also good tolerance, good adherence. I'm rushing because I think I'll take 2 more minutes, Chairperson, sorry. Long-term effectiveness of the oral ferric maltol is IV ferric carboxymaltose, because people think when there is no absorption, they resort to parenteral. The parenteral is good, ferric carboxymaltose is very good, but this results of the ferric maltose is comparable to IV preparation. The same drug, if you take for 52 weeks, compared with the IV, the result is good. That's why I showed you the comparison. I told you about CKD. In CKD, it can be due to erythropoietin or the hepcidin, that is the hormone which produces a lot of iron absorption problem. So this ferric maltose avoids those unnecessary pathway, and then they get a very good evidence that even in IBD trials, phase 3 AGIS trial, CKD trials and heart failure trials, they proved ferric maltose is good. Ferric maltol is good. It also empowers the patients with chronic conditions. Apart from ABD and CKD treatment, this also helps the patients to recover faster. And then transformative potential, it restores energy, it restores cognitive recovery, and then treatment adherence is good, and they feel well-being, enhanced well-being. So European Union, United States, they already had this molecule. In the Europe, it is promoted as Ferrocure, and in the United States, it is Acarfur. So all this, they have done all the trials, and they've launched the program, tablets, drugs 2-3 years back. Now it has come here also. I think now expert opinion also says gastroenterology expert consensus and clinical pharmacology and elementary pharmacology, they also recommend iron, especially ferric maltol. Now the key highlights, ferric maltol is a novel, stable, non-salt based iron therapy, makes the iron highly bioavailable for absorption, lowers potential for drug-to-drug reaction, effective in treating IDA, causes rapid HB rise, very important, compared to liposomal iron, it causes rapid HB rise, achieves 2 gram DL rise in 12 weeks, so it's proven long-term efficacy till 64 weeks with rise of at least 3 grams. With its favorable side effects profile, ferric maltol improves patient compliance as an oral that is effective as IV iron. So ladies and gentlemen, I conclude, iron deficiency anemia is a multifactorial disorder involving nutritional deficiency, blood loss, and you have to do iron studies. I told you, don't stop with hemoglobin measurement alone. Do iron studies. Somebody is not anemic, don't think they are normal. So sometimes they may have iron deficiency. So in any anemia or even with non-anemia, especially chronic disease, try to do iron profile, and you treat iron, you will be better. Especially if you talk to the cardiologist or the gastroenterologist, they always prescribe iron. When you want to prepare oral iron, Ferric Maltol is the ideal drug. Thanks for the patient hearing.
Thank you, sir. Thank you, Muruganathan, sir. So thank you for that very lucid but important talk. And you did talk about a lot of chronic conditions like inflammatory bowel disease, chronic kidney disease, especially heart failure, where we see iron deficiency. And bioavailability and not affecting the gut microbiota is very important. And you did demonstrate that ferric maltol is one such iron, which is very good. And it is good in correcting the anemia as well. So thank you. In the interest of time, we won't have any questions now. If you have any questions, you can interact with sir outside. So thank you.
I'm very glad the chairperson has observed clearly and summarized what I said. Thank you so much.
Thank you so much, doctors. Thank you so much, speaker and the chairperson. Request you to move to the selfie area for the memento.